Hi, and welcome to another episode of HeartCore Junction. I have a returning guest today, and his name's Dr. Kevin Ning. He's a leading consultant cardiologist and electrophysiologist, and he specialises in sudden cardiac death, congenital heart disease, and heart failure management. Please welcome Kevin. Hi, Kevin. Thanks for coming back for another podcast.
My pleasure completely. I had such a good time the last time. I'm hoping that we'll have such a good time again today.
Now, you are specialised in congenital heart disease and sudden cardiac death. So I thought we'd speak about that today. So I know the subjects can be intertwined as well in this podcast. So let's start with, what is sudden cardiac death and sudden cardiac arrest, and how does one lead to the other?
Great question. So a topic that's very dear to my heart, as you can imagine. It's something I spent quite a few years studying and researching on. So a much bigger problem than we would like in Australia for sure. So just to give you some numbers, last year about 25,000 people dropped dead suddenly in this country, which is a large percentage.
That's huge.
And the worrying thing too, and not that age in terms of someone who's older is less important than someone's younger, but somehow we expect a lot more when you're a bit older. But the worrying thing about sudden cardiac death is it can affect anyone of any age. And like you said, the big differences between sudden cardiac death and perhaps other causes whereby the heart could stop is that the sudden cardiac death is usually an electrical problem. Essentially, like what we said before, the electrics control the speed of the heart and the rhythm of the heart. And sudden cardiac death is usually caused by a particular arrhythmia called ventricular fibrillation. And as we said before, it's when the heart becomes completely erratic, nothing's controlling the coordination of the heart anymore, and if the heart was to maintain that erratic behavior, after a while it will stop. So sudden cardiac death is that worrying state whereby all of a sudden you go into this dangerous arrhythmia, and if no one is there to fix the arrhythmia for you then and then, the heart can stop. Now that slightly differs from other terms that people have used before, such as heart attacks. So heart attacks is mainly a plumbing issue. And as you know, when your blood vessels get blocked, either because a blood clot has formed within it or it's narrowed over time and not enough blood is getting to the heart, it can cause sudden cardiac death as well. Essentially what we're saying is a heart attack is a cause, or one sudden cardiac death is a result of a heart attack as an option.
Yeah, I'm glad you specified that, because people do get confused between a heart attack and cardiac arrest. And, you know, one is the block plumbing and the other one is an electrical conduction issue. So what is there an age-specific cohort that is more at risk of sudden cardiac death?
Unfortunately, as we said, it affects everyone. And definitely when we're older, the statistics will suggest that if you were over the age of 50, you have about a 1 in 1,000 chance of dropping dead suddenly. And that's because as you get older, you start developing issues that cause structural heart changes, of which the most common is a heart attack. So certainly the cohort of patients who have unhealthy lifestyles, for example, or the same risk factors that to develop a heart attack, then your risk of sudden death increases as you get older. However, for the younger population, so those under the age of 50, especially those under the age of 35, a lot of the time, their causes for sudden cardiac death is related to something inherited. So either an inherited arrhythmic issue or an inherited structural heart issue called congenital heart disease.
When you talk about the inherited congenital, there is one called long QT syndrome. And I know it was diagnosed in 1957 by Javel and Lang Nielsen.
That's right.
And it was with 4 children in the same family, I think it was, that had this recessive gene. And it was a normal structural heart they all had, and yet they also had a commonality of congenital deafness, I think it was, wasn't it?
That is right.
Can you explain long QT syndrome for us, please?
Certainly can. How long do you have? So a big topic, but as you said, it's one of the inherited conditions that we actually have a lot of understanding about. So as you said, described from many, many years ago. And it's one of those where we've also studied the genes quite intensively. And so we've learned a lot about it. And as you said, the dangerous thing about long QT syndrome is that a lot of patients, the first time they ever present with it is when they actually have a major issue. So either they black out because their heart has gone into this dangerous arrhythmia, or unfortunately, their heart does stop and the first time they present is with a cardiac arrest. And it's one of those conditions, therefore, then, that you are at risk of from the minute you're born because your genes are with you from the minute you're born. And this faulty gene causes abnormalities in how the electrical circuits of the heart form and how the electrical circuits of the heart re-energize themselves, I guess. And like we said, the difficulty is trying to diagnose it. Unlike certain conditions where you can do an ultrasound or a cardiac MRI or something to image the heart to then tell you there's a problem with how the heart looks, when it comes to long QT syndrome, the heart looks completely normal because the issue is to do with the electrical circuits. And you don't see it until certain parameters are in place, all those little holes on the Swiss cheese all lining up in that unfortunate circumstance, and people then can have a cardiac arrest.
Because I know that with long QT as well, it was predominantly when you're a young boy, you're at higher risk. However, when they hit puberty and testosterone kicks in, that risk decreases. And it's the complete opposite for the female. Female child is at lower risk, but when she hits puberty and estrogen kicks in, she becomes at higher risk if she's carrying that gene, isn't it?
Spot on. And these are the intricacies of these genetic issues. Is we know that for all of us, our genes tells us how tall we're going to be, how smart we're going to be, how good looking we're going to be, but we also know that the environment plays a major role. And part of that is that the genes may predispose you to certain things, but how you develop, how your hormones are, they can affect how the actual genetic abnormality then shows up in an individual. And this is why it makes it tricky. And we do think it's most probably related to the hormones when it comes to long QT syndrome and how it's perhaps worse in females as they hit puberty and the hormone starts affecting the heart cycle. The issue, though, is not all women have this problem, and this is why it's a bit of a confusing piece to try to tease out, and it's not just a one-size-fits-all kind of risk stratification protocol.
Because it is what we call a channelopathy, isn't it? It's where the sodium and the potassiums go in and out of the membranes of every cell, and it's just so dangerous, isn't it? I remember there's like 13 genes, of which 3 are the most predominant, aren't they? Which can cause long QT either during sports, exercise, or even at sleep at rest, isn't it? Which is the most dangerous one.
It is the scary one for sure because we all have to sleep. But you're right. So if you were to look at the biggest sense of it, the inherited conditions can either result in changes in how your electrical heart properties are affected, and those are the channelopathies. So that's just purely an ion channel issue versus those that affect how the heart actually works in terms of its structure as well. And there's a huge overlay between the two. They cross over at some point in time, whereby some genetic abnormalities that cause structural heart problems can also cause channelopathy problems. And like you said, though, these channels, and the more we learn about them, we realize that there are different subsets of them. And depending on where your genetic abnormality is, it can produce a very specific type of condition that can predispose people. So long QT is one of those. And like you said, we've learned a lot about long QT. There are quite a few gene options out there now, but fortunately, the majority still falls into the big 3, which are the top 3 causes of long QT syndrome. So long QT1, long QT2, and long QT3. But like you said too, each of them have slightly different features about them that make them specific for that particular diagnosis. But because of that, we can try to treat them more specifically too. So for example, long QT1, we've realized that the majority of the problems arise when adrenaline starts rising in the person's system. So like you said, is usually when someone's exercising, the adrenaline rises, and then it starts causing that particular ion channel to act up. And so that's when we find the highest risk of having an event is when the adrenaline levels are high. Long QT2, for example, is also an adrenaline aspect, but it's more of a huge spike in adrenaline. So when people get shocked or surprised, that's when we realize they're having the most events at that point in time. And the last subtype that's The most worrying is that long QT3, whereby it's sleep this time that seems to predispose patients to getting arrhythmias. And as a consequence, that's perhaps the most dangerous type because we can tell patients sometimes to avoid certain activities, but you can't tell them to stop sleeping.
And it's quite hard to, what are the treatments for it? I know you can medicate and then there is procedures to do, but it can be quite hard to get a young person to take medication all the time, isn't it?
Exactly right. And certainly with the more common long QT phenotypes, as we said, the long QT1 and the long QT2, the way to treat it is to dampen adrenaline. So a beta blocker would be your first line treatment. And it works really well as long as a person takes it. Because the side effect when you dampen adrenaline is that you then lose that pick up and go that you get with adrenaline. And some people feel very tired. And like you said, the majority of our patients are young and active. And that treatment sometimes makes them worse than the actual disease process itself. And so it's about education, making sure that patients understand why it's so important to take this drug. And we've got enough evidence to show that if you take a beta blocker and you have a long QT type 1, your risk of having an event is almost negligible to the same risk as someone without that problem, as long as you take that beta blocker. But naturally, if all fails or if a patient is unable to take a beta blocker, then the best next thing to do is to protect them with these devices, as you have sort of mentioned before, which is the implantable defibrillator.
And what about, is it left cardiac sympathetic denervation?
That's right.
What is that?
So that's a big word to say. What a surgeon will do is they will basically cut down to where the nerve fibers are that produce the adrenaline drive. And that's usually a chain of little nodes that sit next to the spine. And the surgeon can go in there and basically cauterize or remove those nodes to try to dampen the adrenaline response. It's a fairly drastic style of procedure for someone who cannot take a beta blocker. And therefore, it's indicated in those situations, especially children. It seems to work pretty well for children.
And do you go that way for children because they're less compliant with medications because they've got to go to school, maybe they've forgotten their medication? Is that sort of where that procedure would be more suited to children?
It does seem to be that way. Also because, as we said briefly, one way to protect people definitively is to put a defibrillator in. But it's not just for Christmas, a defibrillator is there for the rest of their life. And if you were a 5-year-old and diagnosed with this condition, you don't necessarily want a defibrillator with you that's going to have to be changed multiple times in your lifetime. And as that person grows, the defibrillator could stop working because all the wires and the fibers stretch because the person's growing. So we do find that in the younger person, a procedure like the denervation might save them a few years before needing to consider a defibrillator. But it has to be the right subset of patients as well.
And then when you got a defibrillator in, isn't it? I mean, the battery needs changing.
That's right. That's right. And while people think it's a simple thing to just pop a device in, it's not as simple as that. It's someone has to live with this for the rest of their life, like you say. It is hardware. Hardware in any situation runs the risk of sort of deteriorating over time. Wires could break, fracture, leads could malfunction, devices can malfunction, and all these issues need to be thought about when you try to treat someone.
Okay, so now when somebody's got a defib or a pacemaker, please tell me, can they go through an X-ray machine at the airport?
They most certainly can. Certainly the legacy devices, which I believe hardly any of them exist anymore, so we're talking about devices that were implanted 60 years ago. Naturally, a lot of them most probably are no longer valid. But certainly most of the new devices, airport security is fine, metal detectors are fine. It's important to let security know that you do have a defibrillator or a pacemaker, though, because you will set off the alarm and then they'll worry that you are smuggling a gun somewhere else. So it's not like the defibrillator will malfunction because of the detector, but it's useful to let them know, mainly to save you a bit of hassle rather than anything else.
Then some athletes are known to get sudden cardiac death, isn't it? Why is that?
So it's, I think with the athletes, we're picking on a group of people who use their heart to extremes, I guess. And ironically, if you have an underlying heart issue that could predispose to sudden cardiac death, that's the cohort that's being picked up the most. So it's a fallacy to think that it's athletes that suffer with sudden cardiac death the most. It's more likely just because they're athletic, they're exposing vulnerabilities in their genetic profile that then put them at risk. So certain countries have very strict screening protocols. Italy, for example, anyone partaking in any high-level sporting activities, so school level and above, they have to go see a cardiologist for screening first,
Really?
just to be sure they're not harboring one of these little genes that no one knew about until it presents.
Yeah, because we've seen it on the media a few times, isn't it? Say on a soccer field or something, and somebody's just collapsed from sudden cardiac death. So
That's
it's quite
right.
worrying, isn't
It
it? But
is.
that's great that Italy's got that initiative. Is that the only country in the world that does
No, a
that?
few European countries do. In the States, if they're joining the American national team, they also have to go through that same screening. We're lacking in Australia here because we don't really have a body that tries to represent all these athletes in the same way. But we should be definitely looking at these sort of things because it helps prevent sudden death for sure.
Yeah. And does one cardiac arrest predispose you to having more?
It certainly does. Naturally, it does also depend on the situation for the cardiac arrest. So if you were unlucky and, for example, ended up in a road traffic accident and you were bleeding out, you could have a cardiac arrest because of that. In that situation, it's less likely for you to have one spontaneously again because that's most probably caused by the accident. However, if your heart decided to stop out of the blue for no reason, there is a high risk that it could happen again. And in that population, we would definitely protect them with these implantable defibrillators.
Right. And I remember, on the ward we did the 4H's and the 4T's. And so what about hypo or hyperthermia?
So
How does that affect the heart?
it affects it tremendously. So as you said, there are a couple of reversible causes that we do try to attack first if someone presents with a cardiac arrest, because we know that removing that insult would definitely allow the heart to recover and heal. So if you are hypothermic, as you know, your heart rate drops tremendously because your heart slows down because of the hypothermia. And if it drops down to such a rate that it's not functional anymore, it can definitely cause a cardiac arrest. So those 4H's and 4T's, like you say, still should stay on the top of a list when anyone sees someone with cardiac arrests. But I think you brought up a really good point, and that is one thing about preventing these issues, there's always a personal level. So it's important to identify a patient, treat them well, educate them properly. But there's also this huge public social awareness that's required too. And I think we, as a public servant, at the end of the day, we need to do our very best to educate people. We need to make sure that governments are ready to supply defibrillators in high trafficked areas, for example, where the risk is higher that someone could have a cardiac arrest. We need better education to allow public people who are interested in learning life support sort of courses. They should be available because it's so important. You never know when you're going to need one.
And I'd love to see defibs in every household. We see
be
them in
ideal.
sporting communities
That's
and
right.
restaurants everywhere, but to be able to get them into every household, I know they're trying to get them into more suburbs, but to get one in every household, because they're getting cheaper and cheaper.
They are.
Yes, there's ones for $1,500 and $4,000, but there's ones that are even a couple of $100s. They're quite small, aren't they?
Agreed.
know.
And they're easier to use nowadays too. They used to be fairly complicated. Now most of the time it's all there's a robot that speaks to you and tells you exactly what you need to do when you come to this machine. So it's pretty foolproof, and it should be, like you say, much more available than it is now.
And there's a great company, Defibrillators Australia, everybody. Just go on their website, go and have a look, and please, if you can afford to, just buy one for your family, It's so important.
Especially if you have a family history of these things happening. And we are hoping that with more and more awareness, patients who actually go, my mom did tell me that my uncle, when he was in his 20s, used to black out all the time until he had a special device fitted. These are the sort of things that should trigger people to go, oh gosh, do I potentially have a genetic predisposition for this too? And as a result, I should see a cardiologist to get myself screened, So paying attention to the family markers of the signals is part and parcel of managing these patients.
Okay. And you've just said to be screened. So can you tell us, Kevin, a little bit about what screening and diagnostics do you do?
So history perhaps is the most important aspect. So when you go see a cardiologist for the first time, they'll most probably run through a whole bunch of questions, making sure that you have been well, you're not fainting for no reason, that when you exercise, you're not having any significant palpitations or feel your heart fluttering around for no reason. The history is important there. And then the family history is important too. Like we said, do you have a first-degree family member that's dropped dead suddenly for no reason? Or did someone pass away and autopsy has suggested that there's a familial condition? Things like that. So the history is important. And then usually the investigations are part and parcel of our routine set. So we would definitely recommend an ECG or an EKG, depending on which country you come from. And as you know, that's just an electrical tracing. We would suggest an echocardiogram, an ultrasound scan of the heart to begin with, and then typically a stress test would be ideal as part of the screening tool. Other tests that we could then do, depending on whether any of those tests are positive, include things like MRI, angiograms, and Holter monitoring. So most of these tests are fairly routine. Most of them are non-invasive and fairly simple to do, and therefore always a good idea to get it done if you're worried.
Yeah. And just going to one of the 4 T's, the toxins. So toxins can be drugs, illicit or not. So can you explain to us what the effect of drugs, because there's so many prevalent drugs illicit out there, but how that can affect the heart?
So no doctor is ever going to tell you that an illicit substance is ever going to be good for you, and that's
Yeah.
for a good reason. It has huge consequences on the heart. So things like cocaine and amphetamines predispose your heart to these electrical issues. And if you were unlucky and you already had the genetic predisposition for it, taking some of these drugs can actually induce a cardiac arrest. Not only that, these drugs too can cause, especially with cocaine, it can actually cause a heart attack too by causing your blood vessels to spasm. So definitely illicit drugs would be top of our priority to address, especially if a patient's at risk. And there's no illicit drug that's technically safe.
Yeah. And if somebody's having a cardiac arrest and you're a witness to this, it used to be, yes, the CPR and then do the ventilation, which is mouth to mouth. Let's say you're out in a public place, but you don't have to do mouth to mouth anymore, do you?
No, you don't. I mean, obviously, if you've been through the course, you've practiced at it, you're pretty good at it, it's never a harm to do it. But we've realized that the most effective and most powerful thing is the chest compressions. So if you can't give mouth to mouth or not willing to, or there's issues as to why you can't, a chest compression is the best thing you could do. Don't worry too much about the mouth to mouth.
Okay. Good advice. Is there any other warning signs or symptoms that people need to be aware of? Is it shortness of breath? What are the signs and symptoms that we could look out for each other?
So the biggest would relate to blackouts or feeling faint. Now, the issue, though, is that there's lots of reasons why you could be feeling faint. I generally would say that if there's no clear explanation as to why you're feeling giddy, for example, if you stood up too quickly, you might feel a bit giddy for a few seconds. That could be explained by your blood pressure. However, if all of a sudden you feel giddy for no reason, or you feel giddy when you're exercising, then those are usually warning signs that maybe something could be wrong. Exercise is difficult though, because you and I both know if we push ourselves really hard, at the end of exerting ourselves, we might feel a bit giddy or faint or nauseous because we've pushed ourselves really hard. That's not too much of the issue. It's more when you are exercising and when you're doing that run at that peak of exertion, you feel symptoms, that's when you should get it checked out.
We've talked about the congenital heart disease, but it's more rhythm related. But there's actually, like you mentioned before, the congenital heart disease that's more structural. Like, for example, the aortic valve, that should be tri-leaflet, and sometimes you're born with bi-leaflet, bicuspid. And then there's also holes, isn't there, in the septal wall, either the atrial septal defect or the ventricular septal defect. Can you just explain to the audience what all of that means? Big question.
It is a big
sorry.
question, but I think you hit the nail on the head. These are issues that when your heart was forming, it never formed to its completion, or formed in a malformed kind of way. So these holes in the hearts you talk about, they do get confused sometimes because some holes in the hearts are actually common and they are just a residual leftover effect rather than actually a problem. But some holes can be problematic for sure. And like you say, the issue is that there is now unusual communication between chambers of the heart, and those can cause problems. But like you say, though, the most common, perhaps, congenital abnormality are these bicuspid aortic valves. The issue with them is that over time, they can narrow quicker than a normal valve function, and these things can cause massive problems too. When it comes to inherited conditions, though, and this is where it gets confusing, I think when people use the word congenital, it just basically means you were born with it. But you could be born with it because there's an abnormality in your genetic profile that's made it abnormal, or you were just unlucky and that when your cells were forming, they formed in a unusual way. And that may not be a genetically inherited condition, if that makes any sense.
Yeah, it does.
So
yeah.
there's two aspects. When it comes to the inherited structural diseases, I think the most common that you may have heard of is hypertrophic cardiomyopathy. And that's actually a lot more common than we think. I think statistics now are suggesting maybe 1 in 500 people may harbor the gene that can cause hypertrophic cardiomyopathy.
That's a lot.
And it's a lot more than we think. But the good news is that most of the time, these patients don't suffer too many consequences until they're much older. But every now and then, especially in the news, especially those young athletes you hear about every now and then, these young patients, they do drop dead because of this condition. And once again, not being able to screen for it effectively has been the major problem as to why these patients are being missed.
Can you break down those two words for us, please, Kevin? Hypertrophic cardiomyopathy, so the audience knows.
So another big phrase, I'm sorry. And so it literally just means that you have a thickened heart muscle. And that's what the hypertrophy means. And for all of us, as we age, our heart muscle is at risk of thickening, especially if we have conditions like hypertension, where you imagine your heart's pumping against high blood pressure. After some time, like if you were flexing in a gym, your muscle will start thickening and start becoming bulky. So that's related to high blood pressure. However, hypertrophic cardiomyopathy is a genetic condition where there's an abnormality in the genes that code for the proteins that make up your muscle, and that protein's abnormal, so it becomes too thick and becomes scarred very easily. And when the muscle becomes bulky like that, blood flow could be obstructed as it tries to go out of the heart, and that scar tissue can also cause arrhythmias to form too.
So can these conditions be sort of undiagnosed for many, many years?
It can. And this is the issue, is that lots of patients would notice, oh, I'm getting a bit older, so maybe this is why I'm getting a bit more breathless. They put down their symptoms to something else. And so that's why a lot of patients don't get diagnosed until something drastic happens. What we're trying to do as a group, as a society, is trying to identify families who might be at risk. And nowadays, there are lots of registries out there now, whereby if a patient drops dead suddenly, their names enter a registry. And if, for example, another family member in a different state also has an event, they can be linked together, and then that whole family can then be investigated properly. So we're hoping that these issues become less of a problem, and we're going to identify patients earlier in their journey.
Yeah. And it's always important to just not forget the families, isn't it? Because it can be so stressful for a parent to think, oh my goodness, my child's just fainted or lost of consciousness, oh, must be dehydrated, or, it can be so underdiagnosed until, unfortunately, it's fatally too late.
And conversely true too, that some patients where they know that they have a family history of something, they just get paranoid or so petrified they don't live their life normally. And this is why it's important to get evaluated, because it just doesn't mean that if you have a genetic condition that you will have it, or there's one that runs in the family, it doesn't mean that you'll have it too. In fact, most genetic conditions, it's a 50-50% chance for the majority of them. And so having yourself looked at is not only to diagnose you, but but also to then undiagnose you and say, hey, look, there's actually nothing wrong with you. You have nothing else to worry for the rest of your life. So getting assessed is a good thing, not only to make sure that your risk is being identified, but to then also say that, hey, you're normal. You don't have to worry about living your life as well.
Yeah, and that it doesn't get diagnosed as something else or misinterpreted as maybe epilepsy or
That's right.
something.
That's right. And at least the treatment can be catered correctly. And I think, like you said, the tough thing when it comes to genetic conditions, it's not an individual problem anymore. And we do deal with families, big families, for example. And it's actually understanding the impact on each family member has a very, it's fairly broad. And we need to make sure that we look at all those aspects for sure.
So when somebody gets an pacemaker inserted or a defibrillator, can you just explain, does every defib have a pacemaker in it?
Yes, it does. So all defibrillators are made off the same platform as pacemakers are. The biggest difference is that in the battery box itself, it's got a capacitor. And as you know, the capacitor allows that device to store a large amount of electrical energy and then to release that electrical energy quickly. So all defibrillators can pace, but not all pacemakers can defibrillate.
Because a pacemaker really is for somebody that's got either complete heart block, where the heart rate goes low and you've got a nice lower limit in your pacemaker, maybe always set at about 60 so that your heart rate doesn't bottom out into the 40s and the 30s anymore. Whereas a defibrillator is the little box that's going to actually shock you in an electrical cardiac arrest.
That's spot on. And I suppose you could look at it this way, that pacemakers are there to treat slow heart rhythms. Defibrillators are there to treat fast heart rhythms, fast, dangerous heart rhythms. And so sometimes they have to be used together because someone could have both.
So how long does a defib or a pacemaker last for?
Thankfully, with technology, they last a lot longer than they used to. I remember when I first started, a pacemaker battery will last maybe 7 years, 5 years if you were unlucky. Nowadays, though, they last between 10 to 15 and sometimes even 20 years. So the batteries have gotten a lot better. Defibrillators, because they need to store or produce a greater charge, their lifespan's a bit shorter, averaging around 10 years still, though. So much better than they used to be.
And so is it that they're going to last longer if you have more of an intrinsic rhythm? Is it more, or versus if it's being used more and you are pacemaker dependent, is that battery life going to shorten?
It is, that's right. So if your device was only there to treat you intermittently, and you're going to get treatment either from pacing or defibrillation very rarely, then chances are your battery is going to last a good lifetime. However, if you use it every day, then chances are it will deplete faster. There are other little factors too. For example, as the lead ages, you might need more energy to stimulate the heart, so that will drain more battery too. So older devices might not last as long as newer devices too.
And they're getting smaller and smaller, these little pacemakers, aren't they?
They certainly are. Technology is definitely heading full steam ahead. What we're realizing is we can miniaturize things even better. And also by miniaturizing them, you deal with less hardware. And when you have less hardware, there's less risk involved. Things like infection, hardware breaking, hardware causing other issues because they're physically there and obstructing things. Definitely, the landscape is changing, and I think in 10 years' time, we'll be seeing a whole bunch of different types of pacemakers and defibrillators.
Yeah, wow, because there's ones that look like a little small pill, isn't it?
That's right.
That just sit in the ventricle.
That's right. So they're called leadless pacemakers, and as the name implies, there's no electrical wire anymore. Everything is now miniaturized and combined into a small pill-size device that gets delivered using a catheter, usually through the big vein in your leg. And so there's no physical scar on your chest anymore, because in the old days, to implant these devices, we have to cut through the skin and bury the little battery box underneath the skin, which obviously left patients with a small scar, a small bump on their chest. And these devices, obviously being so superficial, can get damaged by physical trauma too. So lots of benefits beyond just the lack of hardware in the heart, but also patient satisfaction because they have less issues with a visible device.
And why do you sometimes put a pacemaker in the axilla, which is under that left side there? Why do you sometimes put it there? Predominantly for women?
No, well, I have to admit, not many pacemakers are put in that position anymore, but a certain type of defibrillator is. And that defibrillator is a slightly special one. It's called a subcutaneous defibrillator. It's one of the newer defibrillators out there. It's a defibrillator whereby there are no electrical leads in the heart. Everything gets surgically placed on the outer surface of the heart. And as a result, that battery box needing to produce more energy because it's not in the heart anymore is a bit bigger. And therefore, the best place was underneath the armpit area, so it's not in the way on the front of the chest where it usually is for other devices.
I've just known it for a few women that I've looked after. It's quite uncomfortable because it's right on that bra line, or it's like lying down on that side can be quite painful.
It is, and patients have to get used to these things. And this is why technology is moving away from having a separate generator that sits underneath the skin and everything's miniaturized. Defibrillators, unfortunately, we're not quite there yet because, as we said, the battery has to be large enough and the capacitor has to be big enough for it to be miniaturized. But we're definitely heading away from having surgical scars so that patients can live a better life without having all these things to get used to, I guess.
So if I could ask you now, what's one thing about the electrical conduction of the heart that you want to pass on today?
I think that one of the best kept secrets of the heart is that your heart can pump on its own for sure. You don't need your brain to tell it what to do. You don't need any other electrical organs attached to it in any way or form. It's a self-propelling device or organ. And just to give you an example, if you had a heart transplant and someone moved a donor heart into a recipient's body, that heart will have its own starter plug from the get-go. It can just beat outside the body without any issues. And therefore then that transplanted patient actually will have their own starter plug a lot of the time and the new starter plug, and they both work in unison. So all these amazing facts about how the heart can just function on its own is such a wonderful thought.
It's incredible, isn't it? I love the heart. It's the boss.
It is.
Isn't it?
It is. It's to me, it's the most important organ in the body, but I suppose I'm biased that way.
You are.
Yes.
So tell me, what's a week in the life of Kevin like? And I'm imagining, okay, you've got structure. You're doing procedures on this day and this day. You're doing patient contact on this day and this day. And then you've got emergencies all in between. So how does a week for Kevin look like?
It does get busy. And you do have to juggle a few things all together. But it does change day to day. I think the benefit of being a doctor is that no two patients are always the same. And so it's always the excitement of meeting someone new, learning about them, and then doing what you can to help. But like you say, the day is usually interspersed with procedural work, with consult work, and always a little bit of research, hopefully thrown in every now and then, because I think it's important that we need to keep improving ourselves and learning more and more with newer technologies. We always need to stay abreast of these things too. So a week in the life of Kevin is definitely busy most of the time, but hopefully rewarding most of the time too.
Your phone's been going.
I know it has, yes.
Kevin, can I ask you, how do you stay healthy?
I think.
What do you do?
Well, I think we are all guilty of needing simple pleasures every now and then. We all have a little vice or two every now and then. For me, it's always about moderation, keeping check on, realizing that as we age, we can't do the same things we used to do when we were younger, and looking after ourselves that way. So I think we spoke about it at the last podcast, but I think health is not only mental, it's physical and also spiritual. So I think looking after yourself needs to be looked at all three aspects.
You do a wonderful job, and thank you so much for coming again to chat to me. And I really, really appreciate what you do in this space. It's fantastic.
No, thank you. Pleasure's always all mine.
Thank you. Thanks for watching another episode of HeartCore Junction. Please like, share, and subscribe. And if you want any more info, please have a look at our website on heartcorejunction.com. Thanks for watching.